regaining diabetes control, regaining diabetes control in post-COVID recovery and clinical practice recommendation for the management of T2DM will be a very exciting topic for everyone who is attending this webinar. Let me introduce first Dr. Mithun. Dr. Mithun Bhartia, he is MRCGP and MRCP UK. He is basically associated with Mayo Clinic USA, FEC SM Amsterdam, and has got a lot of publications and awards and prizes for his work. To note, that is Zognioti Newman Prize 2013 for his work in diabetes. He represents India at the Worldwide AGP Clinical Academy and is a very renowned clinician in India. Let me welcome his first, Dr. Mithun. We welcome you as a chairperson for this webinar, and we are very thankful to you that you have shared some of your valuable time with us, and we are very kind enough. You are very kind enough for us. Now let me introduce the first speaker, Dr. Debasis Giri. He is consultant endocrinologist and diabetologist practicing at Kolkata. He is medical director, Sugarline Academy of Health Sciences, Kolkata. He is MD DM and has got a lot of publications and talks under his belt in the last so many years of his practice. Today he is going to speak on this topic, and I'm sure everyone who is attending this webinar will be immensely benefited with his talk. Not to take more time on this, let me hand over the session to Dr. Mithun, and then he will invite the speaker for the webinar. Over to Dr. Mithun.
Thank you, Mr. Manish, for the warm welcome.
Yes, sir.
We're going to have a discussion, and I think I would request the speakers that we have more time at the end for, discussion, because we have a good amount of participants there, and so we could have more of a dialogue at the end, and to touch upon the clinical, practical tips far more, and I'm sure they would do that. Just to set the moment, we are, I think, in a new era. In life was previously divided when we were in school into BC and AD. The life is now going to be divided into before Corona and after Corona. And I think when an acute condition comes into prevail, a chronic condition actually takes a hit. Because when all the resources are diverted to look into the acute scenario, a chronic condition like diabetes worsens. And the worsening of the chronic condition makes you a sitting duck for the acute condition, and the mortality and the morbidity is much higher in a diabetic patient. So it's very important in the post-COVID era, we try to regain back our lost territory and get to the momentum back in our game. As we can see, the hockey match that we won against in the, to get the bronze medal in the men's, we were behind, but we actually came forward and regained back our lost momentum. I think to talk about that as to how we can regain our diabetes control in the post-COVID era, I invite Dr. Debasis Giri, who is a consultant endocrinologist. He also works at the Iris Hospital, and he has his own Sugarline Healthcare Private Limited. Over to you, Debasis.
Yeah, thank you very much for this kind introductions and inviting me as a speaker, and for a little bit of discussions on the diabetes management. Actually, it's a COVID-19 era, but we'll be the persons with type 2 diabetes are at higher risk for severe illness from COVID-19 and any other serial illness. As this is the COVID-19 era, we are now being considered as a COVID-19 is the probably most dreaded acute condition now in a chronic disease of type 2 diabetes. And all over the world, starting from Wuhan, China to any part of the world, the morbidity, mortality leading to ventilators, leading to ICU admissions, all were higher with the type 2 diabetes. Two most common comorbidities attached with COVID-19 is the hypertension and type 2 diabetes. So with this background, the CDC have released that 2020 reported diabetes the second most common, first being the hypertension, and every study from everywhere stated that the diabetes is the most common conditions for type 2. COVID-19 severity. 50% of medical beneficiaries hospitalized with COVID-19 had diabetes. One study found 1 in 10 hospital diabetes COVID-19 patients with diabetes died within 7 days of admissions, and 1 in 5 needed a ventilators. So in another study, patients with diabetes and uncontrolled hyperglycemia were more than 4 times as likely to die from COVID-19. So basically, we actually we want to refresh our diabetes teaching, and we want to manage diabetes during an illness. It's not only the COVID-19, but any other disease that becomes serious, and COVID-19 continuing pandemic of COVID-19 actually leads us many things to learn from our old teaching, the 6-day rules of diabetes management, specifically in the patients who are type 1 diabetes or insulin requiring type 2 diabetic patients. They have to follow these 6-day rules. The illnesses, any illnesses most likely to have an effect on the blood glucose levels, any common cold, any flu, including COVID-19, sore throat, UTI, bronchitis, chest infections, any skin infections such as abscesses can lead to debilitating blood glucose control. A diabetic foot infection can lead to a patient into DKA, and even eventually patient may go into death if the blood sugar check unnoticed. And most obviously in the COVID-19 era is the steroid. Use of steroid, dexamethasone has shown the benefit of any patient who is admitted or who needed oxygen. The both mortality and morbidity benefit has been shown by using dexamethasone, and that actually has changed the scenario of diabetes management in the era of COVID-19. Using steroids, and there are also steroid is the most commonly used, abused, and drug, and that actually leads to onset of diabetes, new onset of diabetes, worsening of diabetes, and ultimately diabetes related multiple complications. So whenever you are using steroids in any patient, you have to check his blood sugar beforehand, and if the patient detected to be diabetes or known to be diabetes, you have to use insulin most of the times, and you have to check his blood sugar to give the benefits of steroid to the patient. You always have to keep eye on the blood sugar, because that ultimately will lead to the final outcome. This balance of blood glucose control and the benefits of steroids is very much important in any patients of COVID-19 or any other disease that requires steroid treatment for recovery. So basically what happens when a patient becomes ill is that there is a counter-regulatory different hormones. There's a stress hormone, specifically growth hormone, steroids, thyroid hormones, and different other hormones used. They are become over-secreted to combat the situations, adrenaline, noradrenaline, and all these hormones except insulin, all these hormones are called counter-regulatory hormone, and they actually leads to increase in the blood sugar. This increase in the blood sugar becomes dangerous for the patient who is already diabetes. These hormones can be triggered by any of the conditions, any infections, a cardiovascular ischemic effect, AMI, gastroenteritis, dehydrations, etc. The hormone released during an illness raise blood sugar levels, at the same time make it more difficult for insulin to lower them. That is and the inflammatory conditions itself, systemic inflammation, cytokine storm itself lead to insulin resistant conditions. So the insulin, ultimately the patient will require more insulin to control the blood sugar in any acute illness situations. So for people living with diabetes, even a minor illness can lead to a dangerously high blood sugar levels if you cannot timely increase the dose of insulin and uptitrate the dose of insulin wherever patient is on type 1 diabetes, on completely on insulin, or any other patients who are actually on need insulin. And this may cause life-threatening complications like diabetic ketoacidosis or a hyperosmolar hyperglycemic states, particularly in the elderly populations. So we should always have a plan ahead, and that is called an illness plan. The people living with diabetes and their caregivers, a healthcare team, should always have an illness plan. That is called 6-day rule. They should discuss their target blood sugar goals during an illness, how to adjust their medicines, when to contact their healthcare team for help, how often to check their blood sugar and ketone levels. So when ill, you need extra insulin might be necessary, as the blood glucose levels may rise even if the patients are unable to eat or drink normally. When to contact a doctor, the people living with diabetes should contact their healthcare team if the patient with COVID-19 or any other acute illness, and if they are not sure what to do, if they vomit repeatedly, that is one of the indications that patient is becoming seriously ill. Recurrent vomiting, the dehydration become more severe if the patient actually have vomiting along with illness. If their blood sugar stays high, that is more than 300 or 270 for more than 24 hours, if they develop symptoms suggestive of diabetic ketoacidosis, like hurried respiration, pain abdomen or something like that, and patient gradually becomes stuporous, drowsy, then you should suspect the patient is having a feature suggestive of diabetic ketoacidosis. That should be taught and taught and motivated the patient to contact their healthcare team and doctor. The general guidelines that diabetes medications should be continue as usual. Insulin treatment should never be stopped. Test blood sugar every 4 hours and keep track of the results. Drink extra fluid, that should be calorie free. At least 1 to 2 liters of extra fluid will help to maintain the blood sugar much better than not having adequate fluid. Weigh yourself every day when you are ill. If you are losing weight while eating normally, is a sign of high blood glucose. Check temperature, and specifically in COVID-19 situations also you have to monitor other parameters like SpO2 and pulse, temperatures, BP 6 hourly. These all are important whenever you are actually having infected with COVID-19 and you are diabetic. The general guidelines should be drink plenty of fluids, 120 to 180 ml every half an hour to prevent dehydrations. It might also be necessary to drink sugary beverages if it is not possible to take in 50 grams of carbohydrates through food, or if the patient is at home and have vomiting, that may lead to some amount of glucose to be given to maintain the blood sugar and to continue the insulin treatment to prevent euglycemic sort of ketoacidosis also. The amount of sugary beverages should nevertheless be carefully controlled to prevent blood sugar levels from rising too much. And in a type 1 diabetes settings, when the patient is completely dependent on insulin, it should never be stopped. Insulin dose may need to be increased, and it might be necessary to take additional doses of fast-acting insulin to bring down the blood sugar levels. And most importantly, patient has to check their SMBG as much as possible, at least 3 to 4 times daily before 3 major meals and at bedtime. These are the most important parameters that you have to check the blood sugar to keep it on your side. So plenty of non-sweet fluids should be drunk to avoid dehydrations. And ideal blood sugar levels has been shown that it should be between 110 to 180 to prevent both the hypo and hyperglycemia. This has been taken into account that in a patient who is having diabetes, either type 1 diabetes or type 2 diabetes in acutely ill conditions, and who is treated at home, not in a ICU setting or in a in hospital settings, 110 to 180 milligram per deciliter is a ideal blood glucose level to be maintained. So this is the blood sugar levels and the following ranges at any time. This, everyone with type 1 diabetes should have test strips for monitored blood glucose at home, and if possible also blood ketone strips or urine ketone strips should be there. And whenever you have a positive for ketones, this is the ideal situations that the patient should be admitted, because presence of ketone is actually leading to the patient is going to be more severe and may develop full-blown diabetic ketoacidosis. So along with the management of the COVID-19, you have to always be considered on the diabetes management in a patient with either type 1 or the type 2 diabetes who is totally dependent on insulin. And the insulin adjustment, test blood sugar levels and ketones every 4 hours, day and night. If not possible, at least 4 times a day. If blood ketones are more than 3 millimole per liter at any time, go to the hospital immediately. That patient actually needs intravenous insulin and IV fluids, IV normal saline is actually needed. So the important is that you have to decide whether you increase the dose, you calculate the total daily dose pre-illness. If the patient have a Severe illness, you may increase up to 20% of the total daily dose. And if there is the mild illness, you can increase just 10% of the total daily dose. But that actually has to be monitored, and the blood sugar to be kept between 110 to 180 milligram per deciliters. And follow the chart below to decide how much fast or rapid acting insulin you can add. That is a basically thing that you have to be on. Every hospitals have their chart in a clinic, and any patient who is admitted in an ICU setting should be on a basal bolus treatment for diabetes. And in the basal bolus therapy, you have to give that 0.2 unit of per kg of the basal dose and 0.1 unit per kg of the bolus insulin 3 times, prandial insulin 3 times, and that ultimately have to be corrected depending on the blood glucose levels. Now, the guidelines is most important for type 2 diabetes. In our scenario, type 1 diabetes is much less, but the type 1 diabetes management also put the patient, type 2 diabetic patient who are also on insulin dependent. And in patients with type 2 diabetes, should check whether they develop the following symptoms which may indicate of high blood sugar levels. The patient who were almost well controlled, but after development of COVID-19, when they develop thirst, increased thirst, dry mouth, polyuria, the classic signs of hyperglycemia, that is polyuria, polydipsia, and polyphagia, passing large amounts of urine, tiredness, weight loss. These are all signs of having a high blood sugars, whether it's a COVID-19 situations or the patient is actually having any other acute illness. But in this COVID-19 era, any patient who got infected with COVID-19, it's advisable that they should buy at least, along with the pulse oximeter, they should buy a glucose meter. If they already not have it, you should have a glucose meter and check the blood glucose as many times as possible, at least 3 to 4 times a day. And you have to increase or decrease your insulin, or you have to be with your clinicians that you need to increase the OAD, or you have to be put on insulin for this acute illness. Persons with type 2 diabetes, if take metformins and SGLT2 inhibitors, these are the two important medications for the oral anti-diabetic agents in type 2 diabetes who are on metformin and SGLT2 inhibitors. If we are suspecting that patient can be dehydrated, it's better to stop in the fear of metformin, in the fear of lactic acidosis, and SGLT2 inhibitor in the fear of AKI for the dehydration part. But otherwise, if the patient is well enough, the patient is conscious and take adequate fluid, it has been shown that SGLT2 inhibitor can have some better benefits. And the most well tolerated drug is the DPP4 inhibitor, that should be continued. There is no harm. And when the patient is on sulfonylurea, you should be cautious enough to prevent the hypoglycemia when the patient is not taking adequate fluid. But sometimes you can have to increase the dose when the patient have a higher blood sugar levels. But if the patient is actually becoming gradually ill, and if the patient needed steroids, you have to put them on the insulin, and according to maintain the blood sugar between 110 to 180 milligram per deciliters. So people with type 2 diabetes on insulin must be provided with the equipment needed to test their own blood glucose levels at home. The aim should be to keep the blood glucose levels between 110 to 180 milligram per deciliters. And if blood glucose levels stay above 180, they should increase their insulin dose. Extra blood glucose testing will often be necessary. Testing should be done every 4 hours, especially if the blood glucose levels are high, more than 270. And if the ketone is positive, then probably patient need intravenous insulin through insulin pump. Also, patient should be admitted. So high-risk patient, we should always identify if the patient is a high-risk patient and whether the patient is going to ICU or not. If the patient is going to ICU, then definitely OAD should be stopped, and either a subcutaneous insulin or intravenous insulin should be started. When the patient is serious enough, initially with a high CRP, elevated creatinine ratio, HbA1c, higher HbA1c, hyperglycemia, abnormal blood gas analysis, then the patient should be on IV insulin for at least 24 to 48 hours. And when the patient become conscious or take adequate fluid, then can be shifted to subcutaneous basal bolus therapy. In an IV insulin infusion setting, we should continue checking the SMBG 1 hourly, and the indication is that the guideline says that we should maintain the blood sugar between 140 to 180 milligram per deciliter in an ICU setting to have the most the most wonderful welcome is the outcome is the with between 140 to 180 milligram per deciliter. So that is the reason why every guidelines, starting from NICE guideline or any guideline in the in-hospital management, they are telling that to prevent hypoglycemia and much hyperglycemia, we should continue IV insulin infusions till the patient becomes stable. And continuation of AC inhibitor or ARBs should always be considered. If the patient have a sudden fall on EGFR, then only you can stop, otherwise you should continue. When the patient is not in a ICU setting, in a normally patient is on a room air or just on oxygen, then we can continue DPP-4 inhibitor, GLP-1 receptor analogs, or subcutaneous
It's
insulin.
9 o'clock.
So there are multiple recommendations for persons with diabetes, and in a COVID-19 pandemic, the inpatient diabetes service will need to continue and potentially increase capacity with need to team approach. There is always a face-to-face consultation should continue in the following circumstances, like a new diagnosis of type 1 diabetes or a new diagnosis of type 2 diabetes with a very high blood sugar, and routine diabetes care should always be continued, and the patient should be always motivated and educated enough to tackle the acute illness situations like the situations of COVID-19 infections. So thank you very much for your patient hearing, and I'll be happy if we can have
Thank you, Dr.
questions
Debasis.
directed to me. Yeah, I have made it crisp.
That was an excellent talk. May I request all the audience that if you could type in any questions you would want Dr. Debasis to answer, I would request them to kindly type in the chat box, and then we can take those questions. To get the ball rolling, I'm going to ask a few questions, Dr. Giri.
Yeah.
See, as you have very discussed in deep as to what are the problems and how we go about anti-diabetics. So a new onset diabetic post-COVID comes to our clinic. What would be your first choice of oral anti-diabetic that you would like to prescribe? Among, if all is well, creatinine is fine, all other comorbid factors don't exist, what would you have any preferred choice as to going in this post-COVID era?
Yeah, there is no particularly preferred choice, but it always depends on the baseline HbA1c of that patient. And for me, if it is less than 7.5, I can go only with metformin, or if it is between 7.5 to 9, I can go with a double or triple therapy, even oral therapy. And among them will be metformin, and DPP-4 inhibitors are my favorite choice in this era of COVID-19 because of the poor follow-up of the patients, and there is a most tolerable drug to initiate with. And secondly, if depending on if the HbA1c is more than 9, I may start with insulin for a quite short period, like basal insulin, and sometimes for 10 to 15 days. And after the glucotoxicity part is over, I can continue with metformin and other oral agents, most of the time either a DPP-4 inhibitor or a SGLT2 inhibitor to initiate with.
Okay, I think that's a valid point. HbA1c would help us guide. Yesterday I had seen a patient, or today actually I had seen a patient who had come 1 month ago, was diagnosed in hospital, had steroids, everything, was diagnosed to have COVID, and recovered, came to the clinic, was on insulin previously, now he's on a gliptin and metformin. But the HbA1c, the problem is, if it's a new onset, then the preceding story will have a, like the first
definitely.
marriage, like the first girlfriend always have a lingering effect on the marriage, or the first marriage has a lingering effect on the second marriage. The previous couple of months of HbA1c might have a lingering effect. So what would you advise the audience? How, we should go about that, and what sugar readings, and how can they guide up to the aggression of the therapy?
Yeah, regarding the management of diabetic patients who already have a steroid-induced diabetes or a COVID-19 related new onset of diabetes, we should start the patient most of the time with a dual therapy or triple therapy, and we should try to maintain the HbA1c at least initially below 7.5, and when the patient is quite enough, the patient is educated enough, and the patient is fit enough to do all the exercises to maintain a good diet, then we can try 7 or 6.5, depending on the age of the patient and the physical ability of the patient. We can target either 7 or 6.5. But for the initial who is recovering for COVID, you may give little relaxations up to 7.5.
Thank you so much. Thank you so much. I'm just looking at the chat box. I cannot see any questions. So what we can do, let's move on to the next speaker, and the end we can have more discussion based on the questions. So thank you so much. Now it gives me great pleasure in inviting Dr. Debasis Basu, who's a senior consultant diabetes at Apollo Clinicals Hospital, Calcutta. Joyma sir, he's going to speak. Dada has to unmute.
Okay. They have unmuted. So I was trying to gesticulate and really barge in while Debasis was speaking. It's nice to see, after such a long time, Dr. Bhartia, I would just, if you allow me, I just take this opportunity. Obijit, they have unmuted, so you can hang up. Yeah. I would just, I'm extremely fond of this new concept of this new onset hyperglycemia. And we are, few of us are extremely happy that we have so many patients or clients, or rather, whom we would got to see time to come. The point is, these new onset hyperglycemia, they have additional, the responses of perturbations that is happening in terms of glycation of the ACE2 receptors. There's excess, the cytokine release, what talk about the storm, and the much more important, the prothrombotic state is overexpressed, with increased antithrombin 3 production. So we have understood that this new onset hyperglycemia has much sinister prognosis. So as my brother Debasis was talking about the management, I would personally, kind of accost and say that initially, obviously there's no question of A1C. Maybe we know that in 4 weeks, the A1C can shoot up by, as we say, 1.5% every week. It can shoot up to more than 6. So a standard person, standard non-diabetic individual with 6.5 can come as a new onset diabetes case, even with 12% in the last 6 weeks of what is happening through. And now with post-COVID and long COVID, we are getting to see all these cases more and more. And with a prolonged corticosteroid administration, I personally would be in favor of actually giving them insulin for a prolonged period. And of course, doing these continuous variable glucose monitoring, etc., to adjust to their lifestyle, the new lifestyle that they will now think of. So I was kind of gesticulating to speak out and say my
No, I agree. And I think something which I do as well, in patients who had hospitalization, who had the full, mecca of treatment, I kind of way away from SGLT2 for the first couple of months because of, prothrombic state being, there's a higher and you don't want to dehydrate them. So I kind of dither away from everybody who has had an admission to take them off SGLT2 for at least, because we know the mortality is high in the first few months. So I kind of try to take them away. That's my practice. But I think we'll have more discussion at the end. So Debasis, nice to see you after a long time.
Same here, same here.
And over to you, sir.
By the way, I'll be very honest with the audience. I was given to understand that there are 4-5 sets of slides which Alvu was kind to give it to me. Unfortunately, till the evening, I was under the impression that I would take away that COVID and speak. But my brother Debasis was smart enough, actually being much younger, to gulp that down and talk on it. And I'm now supposed to do this magnitude of diabetes. So this is a slide deck which the company has given, and I have the disclosure is I have no academic or intellectual input in that. I will just read out the slides. So please bear with me. It talks about the gory details that diabetes has the kind of august privilege to shake that fear in us. And if we can now know these numbers, keep these numbers in mind, I think as professionals we ought to be also careful and very somewhere stringently monitoring our cases to see that these numbers shouldn't worsen anymore. So can I ask whoever is on the board to share the slides, please?
Mr. Abhishek, are you going to do that?
Sir, I'll do it now, sir. Yes, sir.
Abhishek Babu, slide below.
Yes, sir. I'm conscious, sir. I'm conscious.
In the meantime, I request if any audience has any burning questions to kindly type it off so that we can at least take it up. We have a lot of audience, but I see a lot of mute audience. I would like all of them to participate.
In fact, I was thinking we will go through the slide deck a little bit, and we can just invite the audience to ask any kind of question that they face during their clinical practice as something to be answered by people like us.
We could do that, Debasis, and maybe I think that then going through the motions of the slide deck, you could give a gist of the slide deck.
Yeah, I will. I'll do that.
That would be.
Yeah.
दिख रहा है अभी? Sorry, can you see the slides, sir?
It will come. It is just coming. Yeah. Wow.
Okay.
It has come. Yes.
Okay.
Thank you. So we have. Thank you, Mithun. Thank you, Debasis, and of course, thank you, Algor, for giving me the chance. Now we are supposed to talk on diabetes and the magnitude, the power of diabetes. So diabetes, of course, are referred to as a group of diseases characterized by high blood glucose levels. And it is caused by either deficiency in the production of or the function of insulin or both, which can occur due to various reasons. And now we've just discussed may also happen due to such inflammatory states like COVID. But finally, that would lead to a kind of it's a kind of overarching, whether it's a protein, lipid, all the metabolic disorders can ensue from this set of diseases, which we club together as diabetes. So we have heard about the symptoms, signs, etc. But now today we'll be discussing on what is the magnitude of it. We know that it started, the next slide. The documentation that we have, that it is one of the first diseases described in the Egyptian manuscript, and it is almost more than 3,500 years back. And of course, in our Shushrup and Chorok, in our own, we have the first evidence of type 1 diabetes as well. We call this disease in India Madhumeha, which is obviously diabetes mellitus. Mellitus means honey, diabetes siphoning, and which is because the urine used to attract ants. And of course, Thomas Willis in the mid-60s, 1600s, he tasted that to be sure for all of us. Next slide. So it is, of course, the most prevalent NCDs. And I remember, I'll share with you, I remember when Dr. Azad, Ghulam Nabi Azad, he was the then Minister for Health and Family Welfare. He went to the UN General Assembly in 2012, and he was given a very rough grind by the UN, saying that what are you doing about the NCDs? You are actually still, spending a lot of time and energy and money on tuberculosis, on malaria, etc. But the numbers of people dying from NCDs more than 5 times that. What are you doing about it? So he came back, and as he was rummaging through, the data that he could find in India, he somehow bumped into one of the papers where it was saying that Diabetes Awareness in You, the organization which I've been, I have obviously the Alliance, it's my organization for the last 15 years. We raised the slogan, Boyosh hole 30 bochor, blood sugar test proti bochor, annually test blood sugar 130 plus you are. Garbhavoti holen jini dektei hobe tar chini. Once you're detected with pregnancy, blood sugar test is an urgency. These two slogans we raised in 2007-8, and this was obviously published in Anandavaja Patrika and Telegraph. In 2012, as he was rummaging through the set of paper and the records in history, he found that this organization in Calcutta has already launched this kind of slogan for NCDs, and he called us, or called, gave me a call, and we went from the organization. He asked our permission whether he can actually imbibe these two slogans into framing what is called to the National Program for the Control and Prevention of Cancer, Diabetes, Cardiovascular Disease and Stroke, the NPCDCS program, the first NCD program in India. So I'm very happy and proud to share this with my brothers. And this is the state, this kind of status that Alvio is presenting, obviously from data, that there are 50 million patients in who are affected cardiologically. The people, this is kind of old data, I believe, but they're talking about type 2 diabetes. So it's around, today the data says 77 million of diabetes, as IDF says, where almost 1 lakh people have type 1 diabetes. Unfortunately, more than 50% of type 1 are never brought into the light because they die from decay before diagnosis. And so we have got gaudy numbers. These numbers that we are talking about, they change almost every minute, every second. We have seen that the projected numbers from 1977 that we talked about is changing rapidly. And especially in the latter years, we have seen that whatever we have projected 10 years from now, we have actually hit that number 10 years beforehand. So many renal transplant cases, so many stroke patients. And the renal transplants, I'll add to this, and I should not be very, it should not sound very derogatory, or I should not be held responsible for making this statement as a non-friendly person who is not talking about the government promoting Ayurvedic and Ayush. With Ram Devji and alike, people coming in 2014-15, in that steam, in that gusto, we have seen the renal transplants almost doubling in the last 6-7 years. So please, the august audience, of course we are all doctors and healthcare professionals, be very conservative when you are seeing a patient who has concomitant Ayurvedic medications. Maybe you will be held responsible for doing no damage to him, but for somebody else. Next slide. So annually India spends 30 billion. This is, I think, old data. We are close to around 50 billion in terms of diabetes treatment and management of complications. Next slide. So this is the annual cost, 34% of the annual household income. I would say in the middle income group, where the patients have gone to insulin and the patients have 1 or 2 complications, whether it's eye complication or microvascular, mainly, whether kidney, eye, or the nerves, they almost spend more than 35% of their household income. Next slide. Next slide. So 1 in 11 adults all across the globe has diabetes. In India, it is around 1 in 9. Next slide. We know that in India, 53% or more of the people out of that, 77, 80. I think we have already 80 million and plus because of the new onset cases that have come out of COVID in the past 1 year. And thanks to COVID, perhaps, that these undiagnosed have become undiagnosed, and they're also new onset because of the stress. Next slide. 1 out of these 5 people with diabetes are above the age of 65. So the elderly population, the geriatric population, of course, because of the reasons of the apoptosis of the beta cells, because with age, as like any other cells which are slowly giving way, you naturally have a natural progression of or expression of diabetes. This is happening, and this is also going. 1 out of 5 people with diabetes, if they are more than 65 years, I think the jurisdictions or the guidelines for the A1C reduction, for the fasting or the preprandial or the postprandial, these numbers ought to change, and we need to also address them adequately. Next slide. 10% of the global, yes, this is the IDF data, goes on diabetes. Next slide. 1 out of 6 live births, I think in India, we can say, South Asia, and in India, especially, I remember Namcho telling us that we published a paper saying that 27% of the girls will become pregnant will have diabetes. And that's the reason I keep saying that we are from the land of in diabetes, and we don't actually say betes. We exclude that betes and club in dia together and call it in short India, because the betes are always kept behind the padda. But here the betes are coming into the forefront because 1 out of 4 and more will have diabetes. And this is how the whole milieu is changing. That we see more number of diabetes today is because perhaps we never paid attention to the low birth weight, the low vitamin B12, D, or folate during the pregnancy, perhaps 30 years and back. And that's the brunt that we are now bearing. Next slide. 3 in 4 people, obviously, we now have around 80% of people living in low and middle income countries like us. And mind you, whatever the numbers of billionaires in India, the poverty scale that we see and the balance between them, we are of course middle income. And I did not hesitate to tell that we are a low income in terms of our expression of the knowledge and our behavior pattern. Next. 1.1 million, that's what I was saying, below 20 years have type 1 diabetes, and India, followed by US, has a huge number of type 1. Next. And this is the pre-diabetes number. Of course, the pre-diabetes, if we have 1 in 11 as diabetes, we have 1 in 13 as pre-diabetes. Unlike the other countries, our conversion from pre-diabetes to diabetes is quite rapid, not like those age-old dictum of 10 years pre-diabetes stage and then you diabetes. We know from Dr. Ramachandran's paper and the ICMR in-depth study that it is a quick conversion. It is now almost becoming 3.4 years that one pre-diabetes is changing to the official definitive diagnosis of diabetes. Next. 2 in 3, of course, live in urban Indias. And this number is also changing because the demographic shift, that is the transition that is happening, is very abrupt and very quick. And the modernization is catching up in the rural places. Less of physical activity is happening for them. They are no more hunter-gatherers. They are getting all the amenities of modern social life. And the politicians are also, giving them, unfortunately and sadly, the lifestyle that they would have lived without, and that is adding to the burden of diabetes. Next slide. So this is, of 88 million people in South Asia, 77 belong to India. We have all the other countries, Bangladesh, Nepal, Pakistan. They are small countries naturally. So we have this. Next slide. This is the epidemiology. We are talking about how much pain it goes for, the diabetic retinopathy numbers, which are growing, and what is the lack of care that we are giving to them. So, and age-wise also, the retinopathy starts worsening. Next slide. With the age-related macular degeneration, etc., happening. High prevalence in Tamil Nadu, Kerala. I won't leave West Bengal and Tripura also. Assam follows closely. Come in. Next slide. So these are the kind of hand-in-hand common soil hypothesis that goes with type 2 diabetes, whether it's micro and macro. They all start together. Previously, we were under the impression that micro starts later after diagnosis of diabetes. Today, we don't say that. We say they almost go hand in hand. In fact, cancer, NFLD, these are not mentioned here. So they are all a part of this continuum. Next slide. These are common complications. We know that heart disease is 4 to 5 times more in people with diabetes. Next slide. So, strokes are more, foot complications are more, retinopathy is more, and 85% of the world foot amputations actually result or come out of one diabetic foot ulcer which was ignored. Next slide. So we have already talked about this, and we have another area where we talk about the brain insulin resistance and the cognitive dysfunction because of the glycation in the neurofibrillary tangles causing the Alzheimer's, and we call it the type 3 diabetes. Next slide. And of course, we have skin problems. We have erectile dysfunction, a very, very common problem, which is almost not addressed, but has a very serious impact on the quality of life, depression, loss of functioning, etc. Yes, this is the cost of diabetes. We know that this is a kind of a survey which was done, and people say that more than 54% they were doing the out of pocket. I think this is more of an ADR developed nation paper. For us, we do, apart from the public hospitals, nearly all of us in the country do a fair amount of out of pocket expense, and which is almost paying through the nose. So I will tell you that though the governments are supposed to give insulins for free, medicines for free, yet at the end of the day, the required number of doses, the required number of strips, the required number of pens or vials are not adequately distributed among the people. And even if they have been, then the storage, etc., the transportation is not so well organized, not so well structured. So the medicine, the insulin that you drive back home or you bicycle back home is no longer worth potent to give you the desired result. So these are the areas where we need to really pep up our thoughts, and whether it's a government or the non-government organizations like our day, we all have to kind of participate with real big strider, and we have to strive, not only thrive ourselves in this run, but we have to really strive ahead for good results. Next slide. So retinopathy, those old pictures. Yes, this is not retinopathy detection. This is urine actually that looking at. This is, I think, the Thomas Willis time where they're looking at the urine. Next slide. Complications, we have talked about it. Quickly run through. We know that the acute complications are also there. We're just talking about the chronic complications, and acute complications are life-threatening. There's no doubt about it. Next slide. And we know that almost 33, we now know that 45% of the people with diabetes come to us with some kind of DKD, diabetic kidney disease in this country. Next slide. Okay, so I think we're done. So we can stop here, and I think I pass it, the mantle to Mithun to conduct the rest of the show.
Thank you, Dada. I would request, I think, Mr. Abhishek, from next time, I think the order should be you keep the magnitude of the diabetes first before we talk about clinical practice guidelines. So the order should be revised in the next meeting whenever you are doing it, wherever you are doing it.
Because they were not certain about the topics. I think that's not. And in fact, I had about talk on nutrition, diabetic specific nutrition at 7:30. So I finished off around 8:40. So I also requested them that let me be the latter speaker, but we could have got a slide deck which could have perhaps suited to this audience as well as that sequence.
Anyway, sir, let me ask the audience, because you have senior people here, senior speakers here, if they have any point they want to ask on anything on diabetes, write on the chat box, because I think it's an open forum. So if anybody wants to ask anything related to diabetes that they're finding it difficult in their clinical practice, I think I would encourage everybody to type it. My comment, Dada has already talked about, I think I would agree that that slide is not a retinopathy slide. Retinopathy that's of a urine slide, as Dada has rightly pointed out. And I think what I would encourage everybody to actually start screening for retinopathy in their clinics and get trained for screening on retinopathy in the clinic. I think that is something I think is really useful. It really helps negotiate the treatment with the patient as well. So I think that would be extremely useful. So let me see if there are any questions. Anybody wants to ask anything? If there is not many questions, I would be very happy to pass back to Mr. Kumar Abhishek for looking after.
Thank you.
Thank you.
Thank you, Doctor. It's been wonderful. I don't know, after such a phenomenal data presented by Dr. Basu, there are no questions, but Dr. Basu, you're pretty good in data. You have given the complete perspective of diabetes in the world and in context of India. And I'm sure diabetes is going to be the big challenge in the next 5 to 10 years in the country. And we will have a lot of patients who are going to be diagnosed newly diabetes after COVID. And certainly this is going to be the biggest burden in terms of the healthcare system or economically, because out of the total expenses which Indians do, it is 60% which is out of the pocket expense on medicines in the India. So it will be a real challenge for the Indians and Indian government to deal with this which is going to come in the near future for us. I really thank you, sir. I'm sure I really agree with you that I think there is one raised hand. Dr. Kamal Bhattacharjee wants to ask some question. Sir, you can write in chat box, please.
Can't he speak? Can't you unmute him?
Can you unmute Dr. Kamal?
I think he's.
I will do it. I will do it now.
He's doing, sir. Just to 10 seconds. He's doing it so that Dr. Bhattacharjee can.
Sir, you can unmute yourself, sir.
Sir, please unmute.
Sir, good evening, sir. Joyma, sir.
Joyma.
Sir, actually the biggest hurdle what I'm facing right now in hospital admitted patient, because of the lack of education to my nurses, it's very tough to achieve the euglycemia in COVID patients. So how to tackle that, sir? It's very tough we are facing, sir. The variability is too much what we are facing, sir, now.
Well, Anshuman, you are talking a very sensitive issue. Unfortunately, healthcare providers, when you talk about that in India, and when you relate that to diabetes, we only talk about us. We have never paid any heed as such in India, I'm talking about, to that beautiful bench of, or the beautiful baby of those people called nurses. And in fact, with Mithun there, spending a good time in the UK, when they mean educators, they actually mean nurses. They mean the friend, right? And everywhere in the European Union, you have really qualified diabetes nurses who are giving the brunt of diabetes care, diabetes education. And as you rightly pointed out, in this kind of a trend where we have been able to understand that COVID has done something which was obviously, which was unprecedented. We have not been able to manage diabetes per se. And even if we have, the transition from the hospital acute setting to a chronic comprehensive home care setting is never very easy, because as doctors, you and I will not have time. So who will take the responsibility to actually address this issue and train the patient and the patient party well? So I think we need to understand that the role of nurses and the other facilitators, maybe the psychologists, the educators, the social workers in any hospital, they should come to the forefront, and they should be trained well. So for the August audience, and of course Anshuman is my son. I will never say he was my student, because I had a wonderful time spending with him in diabetes education and training. He came to me in Apollo from Agartala for a course run by the Royal Liverpool Academy, where I happen to be a bona fide teacher. And we spend good time, and we understand that these barriers are something that need to be addressed. We need you, Anshuman, you, I, Debasis, Mithun, we need to sit with our own people who are actually helping us day in and day out, on whom we have the full trust and faith, to make them diabetes specialist nurses. Today it is 100 years of insulin. And before that, in 1916, 1915, Elliot Proctor Justin, the father of modern diabetes, he had wandering specialist nurses going to people's house for this type 1 diabetes management. So what in 100 years have we achieved in India, so-called the biggest country in the world with the biggest mind and head? We have not done anything. So if we want to really address this seriously increasing health issue, especially during the COVID times, at a global level of performance scale, then we need to train them well. And ladies and gentlemen, we are just coming up from we have a small educational platform called Helios Global Private Limited, from where we'll come up with a nursing course sponsored by a multinational company. And we'll handle these nurses at different segments and make them good insulinizers after we sign off that insulin on our prescription with a question mark and a question mark. Rest, they will take over. I do not know whether the government of India, the legislations, the medical council, etc., will have embargo on that. People hardly will we find people in India helping each other. So we'll have a lot of opposition. But for a new thought, Schopenhauer said, for any good new thought to happen, first you will be opposed then it will be ridiculed, and finally it will be accepted as self-evident. So I'm very hopeful that the role of nurses has to be now very, very seriously emphasized. And Angshuman, you have hit the nail on the coffin. Until and unless you do that, as the advanced caregivers, the role of nurses, we will be nowhere. Without educators, as doctors, we have no role on society to address the problem of diabetes. I again keep on harping and re-emphasizing that.
May I add something, Dr.
Yeah, please, Mithun.
So I think it's a very pertinent question that you've asked, Anshuman. I think one factor that needs to be really considered, if you go to any hospital, and I challenge anybody, go to any hospital, ask all the nurses to demonstrate the insulin technique to you. Not even 80% will be able to do the insulin, dose delivery in the right manner. And that is the raw fact.
Yeah.
And so the problem why we get glycemic variability in the hospital is also because of inefficiency is the wrong word, inefficiency on our part to train diabetic nurses.
Yes.
A lot of my training, I was 12 years in England, and a lot of my training I learned from diabetes nurse how to manage inpatient diabetes. So I think fundamentally, because, and sometimes you see hospital food is not very palatable. Sometimes people bring their own food, and sometimes the duration between the insulin and the food is not actually accounted for, because the trolley comes, and when the trolley comes, nobody knows. So I think that also causes variability. As a practical tip, I use what we are trying to avoid in a COVID, if it's a COVID ward or if it's in an inpatient hospital, we do not want hyper or we do not want hypo. A bit of variability. I would be very happy if the blood sugars are between, say, 100 to 170, 180, 190. It's fine. Let him get discharged, come back. We can get it because his life is going to change while he's not been there. So we don't want hypos, and we don't want the panic red button to be pressed by anybody. What Debasis has suggested, I think it's fine. We are starting a program on training nurses as well, and I'm sure it's nice to know Debasis is also doing something like that, and maybe we can partner something. So something we are starting from an endocrinologist perspective in training nurses, because I think that's the cornerstone of education. But I think the fortune or the misfortune of India is primary, secondary, and tertiary care are not well defined in India. So it's either fortune also and unfortune also. I'm not saying it has its good and bad effects, and because of that, the nurses, the role is also more ill-defined. As doctors are ill-defined, nurses are further more ill-defined. So I think that is where I think needs further more work, and I'm sure companies like Albio would be very happy to have some initiatives on those lines, so that we can get our workforce up and running on that. I think, but a very good question. Thank you so much. There's a
and may I add one more, which is obviously very close to Mithun's heart, I believe, is that in this kind of a setting, which we are not particularly well aware of what is happening during the COVID times, with so much of medication, so much of stress, so much of the stress of fear of the fear of death, the panic of death or dying is so ominous that it sends your all the hormones, all the aggressive hormones skyrocketing through the roof, and you don't have any control on that. So we understand that the patients, there are more than fourfold chance of people with diabetes in COVID-19 meeting the composite endpoint of the need of intensive care. And if there's huge amount of money going in intensive care already, but perhaps a 3,000 rupees investment or a 2,000 rupees more investment for a kind of a AGP, whether it's a flash monitoring or whether it's a CGMS, real-time kind of a Guardian Connect. If we can put it there, right, with the patient's admission, if it's a new onset and old known case, doesn't really make much of a difference to the patient for, in terms of payment, in the economic impact. But the nurses and the doctors, just putting on the sensor, the reader, or, looking at the app, can actually titrate this or address this variability in a much more, comprehensive manner. And I think this is something, Mithun, you and I mean, like all of us, can really push or write a small kind of a, white paper and say that this was the best time. We could have actually, Medtronic or, Abbott for that matter, come together and write a paper. It's just one page, but could have helped, I think.
No, I would agree. I think the problem that has been there is that the education on CGMS is far from good. I remember when Roger was there and Ian was there, and I'd gone around the whole country, teaching CGMS. The problem is, as Debasis has said, anything new and it takes time to people to accept. I think that phase was there. It would have been a handy tool. And perhaps we could have got data on inpatients, because data on inpatients, presently CGMS is not a validated tool for inpatients. And perhaps if there would have been use, perhaps we would have, more use, more acceptability would have been there. And I would agree. I mean, I had COVID, and I can also tell you it is a frightful condition to be there, and frightful condition to be after post-COVID also. And so I always tell my patient who calls me with COVID, he said, I've gone through it so I can understand your pain. And that really helps break the ice. A lot of us would have had COVID. And I think it's important to acknowledge that with the patient, because then he understands that you can understand his anxiety. So, all that fear of dying, that fear of MI, that fear of embolism, I've gone through everything. So, and I think it is a frightful experience going back to work with headaches, with all this. It is difficult. But I think acknowledgement of that, sometimes the patient feels that you can understand his concerns. It really helps. But I would agree with what Debasis has said as well. I think we are coming close to closing time. There is a very short question. There's a question from Dr. Midul Das as to how your opinion on COVID-infected diabetic. But I think there was a long answer to that by Debasis, Dr. Debasis Giri. The whole session was on that. Perhaps, sir, you joined in a little late. But if there is anything specific you want to ask on that, I would ask you to unmute and ask the question to Dr. Debasis Basu. If there's anything pertinent, we can't have the whole discussion on it. If there's any particular point you want to actually clarify, please unmute and ask Dr. Debasis.
It looks like a Northeast. It looks like a Northeast Diabetes Society meeting. Tripura, Assam, all. Where is Kolkata? I mean, where is West Bengal? Abhijit, Kyolo, Kolkata, kyun nahi? No, I'm obviously loving and enjoying to see my own people there, but good.
আমি বুঝতে পারি না 86 মানুষ আছে কা ঠিক আছে anyways I think on that note, if there is no other thing.
No, Mithun is not saying anything. He's not unmuted.
No,
okay,
he's not able to.
We have already unmuted him, sir, but he's missing.
Fine.
So I think, sir, there is no more questions, and you are running short of time. So I'm really thankful to all the delegates who are there in this webinar, and basically all three of you, Dr. Giri, Dr. Basu, and Dr. Mithun, who have done an excellent presentation and discussion and talk on magnitude of diabetes and diabetes complications post-COVID. And the one thing which I like from Dr. Mithun is that he has experienced COVID, and that's why he knows what patient is going through. And that is really going to be very helpful to the patients who comes to him for the treatment. So with this note, sir, I thank you all on this special occasion. And once again, LVO wishes you all the best to all of the delegates and the speakers and the chairperson who are there. And it's been wonderful to have you as a guest and a speaker here. Thank you very much, sir. This is Manish Pandya signing off from this. Thank you, sir.
Have a nice day. Bye-bye.
Thank you, Dr. Basu and Dr. Bhartia.
Thank you.
Yes, sir.
Thank you.
Thank you, sir.